to fight HIV and AIDS in at-risk communities nationwide, and our services are provided throughout 40 states, Puerto Rico, and the Virgin Islands. We have a long demonstrated history of building national, regional, and local coalitions, and our 5 core service areas include direct services, HIV prevention and health promotion, capacity building assistance, or CEBA, using our change model, health disparities using research and evaluation methods, and health policy advocacy and community mobilization. Next slide, please. Specifically with our CEBA service provision, the Hands United program offers CEBA under 3 distinct components: high-impact testing, prevention with HIV-positive persons, and organizational development and management, or ODM. We provide these services under our 5 values of sex positivity, multiculturalism, innovation, critical thinking, and health equity. Next slide, please. So just some housekeeping. Throughout the webinar, we will mute and unmute the lines for questions and comments. To ask a question at any given point, you can use the chat box using your keyboard. You can also press *7 on your phone to talk, and please press *6 to mute your line so that we don't hear any background noise. Next slide. So before I begin, just to give you a little bit of background, I am the Deputy Director of Research and Evaluation here at the Latino Commission on AIDS, and I'm also a CEBA specialist. And I love everything that has to do with epidemiology and evaluation, so hopefully you'll enjoy this as much as I do. For those of you that already have some knowledge or some concepts of epidemiology, this will be a refresher. But for those of us who are new to the field, this will be an introduction. So just to give you a brief overview of what we're going to be focusing on today on the webinar, we're going to review some basic concepts of epidemiology and prevention, including definitions of prevalence and incidence. We're also going to do a brief introduction to HIV epidemiology, and then we're going to review concepts in social determinants of health and how they can be applied to a holistic approach to program planning as well as structural interventions. We also want to review some applications for programming and have enough time for questions and answers towards the end. So let's review what some of the objectives are of epidemiology. One is to identify etiology of disease and relevant risk factors. What does that mean? We want to know how the disease is transmitted from one person to another or from a non-human reservoir to humans. And we want to identify causative factors that could lead to certain conditions. Why is this important? Our ultimate aim is to intervene to reduce morbidity and mortality from the disease. We need a rational basis for interventions, which can be considered prevention. And if we can identify the etiologic or causative factors, we can reduce exposure to these factors. Secondly, we determine the extent of disease found in the community. That question would be, what is the burden of disease in the community? This is critical for health planning and training. Epidemiologists also study the natural history and progression of disease. Certain diseases or conditions have worse outcomes than others. For example, some may be fatal, and we want to understand that this natural history or progression of disease so that we can implement control measures. We evaluate both existing and newly developed preventative and therapeutic measures and modes of healthcare delivery. We evaluate if a program intervention is operating successfully. We also provide the foundation for developing public policy relating to environmental problems, genetic issues, and other considerations regarding diseases, prevention, and health promotion. Finally, we provide the foundation for developing efficient public health campaigns and policies related to disease prevention. Next slide, please. So here's an overview of the top 10 leading causes of death in the U.S. This data is a little bit old. It's from 2015. But we're going to use it to sort of do a bit of an exercise. So as we can see, the number one leading cause of death in the U.S., or the leading cause of mortality in the U.S., is heart disease, with 614,340 cases, followed by cancer, and then chronic lower respiratory disease, unintentional injuries or accidents, stroke, Alzheimer's, diabetes, influenza and pneumonia, nephritis, nephrotic syndrome and nephrosis, and the last one would be considered intentional self-harm or suicide. So we see that the top cause of death or mortality in the U.S. is heart disease. Next slide. Here's an overview of age-adjusted death rates for the top 10 leading causes of death, or again, mortality in the U.S. As we can see, the blue bar at the top represents all cases of all causes. The second orange bar represents heart disease, and we can see that that's closely followed by cancer in the green, which is the third bar going down. So given the information that we just provided to you, what would you think about when you wanted to reduce the largest number of deaths? What would you target? Going back to the information from the previous slide and this slide, the three leading causes, heart disease, cancer, and chronic lower respiratory disease, account for the majority of deaths, an observation that suggests specific targets for prevention if a significant reduction in mortality is to be achieved. However, when considering public health measures, numbers in and of themselves do not necessarily equal disparities. Next slide, please. So why would we want to identify those at high risk of disease? A major use of epidemiological evidence is to identify subgroups in the population who are at high risk for disease. Why should we identify such high groups? One, we can direct preventive efforts, such as screening programs for early disease detection, to populations who are most likely to benefit from any interventions that are developed for that disease. And two, we may be able to identify the specific factors or characteristics that put those at high risk and then try to modify those factors, although some factors are not modifiable. Next slide. Here's a table outlining the three different types of prevention. Primary prevention, which prevents the initial development of a disease. An example of that would be immunization or vaccination, or reducing exposure to a particular risk factor. Secondary prevention, defined as early detection of existing disease, so a developed morbidity, to reduce severity and complications. An example of a secondary prevention measure would be screening for cancer. Tertiary prevention would reduce the impact of the disease. An example of that would be rehabilitation for stroke. So just to quickly review, primary prevention would prevent the initial development of a disease in someone that does not have the disease. Secondary prevention is early detection of existing disease to reduce the severity and complications of the established disease. And tertiary prevention reduces the impact of the disease that's already established. Next slide, please. Here are some varied approaches to prevention. One is population-based, which is applied to the entire population, and in order to be effective, must be relatively inexpensive and non-invasive. You can think of fluoride in the water, for example. A second approach to prevention is the high-risk approach, or sometimes called targeted approaches. This approach to prevention targets those at highest risk for a particular disease. So a priority population in the high-risk approach may receive tailored messaging, whereas the general public in population-based approaches may receive basic health education messages. Next slide, please. Now we're going to go into some terms that are used in epidemiology. Incidence. What is it? Incidence measures the number of new cases of a disease that occur during a specified period of time in a population at risk of developing the disease. It's a measure of disease in people who did not already have the disease at the beginning of the study or the time period that we're following, and it represents a measure of risk. Incidence proportion is a fraction. So think of it as the number of new cases, and the denominator is the size of population at risk for that illness. Uses for incidence measure include assessing risk of disease, determining how quickly disease is spreading, looking at time trends in new cases of disease, evaluating whether interventions are successful, and comparing new cases to new potential sources of exposure when investigating risk factors. Next slide. Now we're going to unpack what is meant by incidence rate. When different individuals are observed over different lengths of time, we can calculate an incidence rate, also called an incidence density, in which the denominator consists of the sum of the units of time that each individual was at risk for and was observed. This is called person time and is often expressed in terms of person months or person years of observation. With incidence rates, when we have information on exactly how long an individual person was at risk, we can calculate the incidence rate and thus have more information on those who developed the disease of interest during a particular follow-up period, the number of people at risk who did not develop the disease of interest, and the number of people who were lost to follow-up. So again, with an incidence rate, you can think of the number of new cases of disease occurring in the population during a specified period of time over the amount of time contributed by each person who was at risk of developing the disease during the defined period of time. Next slide, please. Here's an example. Think of denominator as time, which is the length of time that people are followed. Example, person time or person years, or sometimes person months. In this particular case, think of if one person was followed for 1 year, that person contributes 1 person years. If that one person is followed for 5 years, that one person contributes 5 person years, even though it's still just one person that you are following. Different people contribute different amounts of time to the denominator depending on how long they were followed, and this method is especially useful when you have a small number of subjects or people that you are following. Next slide, please. Now we're going to discuss prevalence. What is it? Prevalence is defined as a number of affected persons present in the population at a specific time divided by the number of persons in the population at that time. It measures the proportion of the population that is affected by a particular disease at that time, and it includes both new and existing cases. It is calculated in cross-sectional studies. A good way to remember this is to think of just like a snapshot. So at any given point, how many people are affected by a particular illness at a particular moment in time. That's prevalence, a snapshot. Whereas with incidence, you want to see how many people develop a particular illness over a particular period of time. How many cases are diagnosed of a particular illness over a particular amount of time. Next slide, please. Here's an example of prevalence. There are 250 people that live in City A in 2016. 60 of those people were diagnosed with a particular illness, T, during that same year, 2016. How would we calculate the prevalence of T in City A in 2016? So going back to our fraction from earlier, you would take the 60 folks that developed the illness at that time, and you would divide it by 250. That would be the prevalence of the illness in City A. Again, this would give us a snapshot of the disease in a community at a given time and helps with planning for healthcare systems in a community, and it can be used to guide resource allocation and distribution of resources and services. Next slide, please. Here we're going to do a little review. 4 questions. Epidemiologists are interested in learning about the causes of disease and how to cure or control them, the frequency and geographic distribution of diseases, the causal relationships between diseases, D, all of the above. And here we can do a poll to see what you think the answer might be. So I'll give everyone a few moments to type in their responses. Okay, it looks like about half of you have responded. Let's give it a couple more seconds. Okay, we see about 10. We have a few more. All right, let's go to the results. So 3 of you chose disease frequency and distribution, and 8 of you, 73%, chose the correct answer, which is all of the above. So epidemiologists are interested in learning about causes of diseases and how to control them or cure them. We're interested in the frequency and distribution of diseases, including geographic distribution. And we're also interested in causal relationships between different factors and outcomes of diseases. The second question is going to be a true or false or yes, no question. Incidence measures the number of existing cases of a disease at a given point in time. Yes for true, no for false. Okay, we're going to go to the results. So this was close here. 54%, 55% said yes, that incidence measures the number of existing cases of a disease at a given point in time, and 46% 6% of you said no, that is not the correct definition. And no, it's not the correct definition. So again, think of prevalence as that snapshot at a given point in time of the diseases that exist, whereas incidence measures the development of new cases over a point in time, over a period of time, excuse me. Next slide, please. So what does all this mean for our work? It's important to understand locations that have high incidence, so a place where a particular illness is developed over a period of time. High prevalence locations, areas that have a high amount of individuals, for instance, that are living with a particular illness. It also is important to understand locations with disparity and disproportionate burdens of illness. And it's also important to understand locations with disparity and inequity in terms of social determinants of health. So there's different ways that we can access this sort of information for ourselves by using surveillance data. The next portion of the webinar, we're going to focus on HIV epidemiology and how we can use some of the surveillance data that's publicly available to us. So just a brief overview of HIV epidemiology in the U.S. The first case of HIV was diagnosed in 1981. Over 1.2 million people aged 13 years and older in the U.S. are living with HIV infection, and almost 1 in 8, or almost 13%, are unaware of their status. This is according to the CDC in 2015. Gay, bisexual, and other men who have sex with men, or MSM, particularly young MSM, are most seriously affected by HIV. And when we look at racial and ethnic backgrounds, we see that Black, African American populations and MSM face the most severe burden of HIV, followed by Latinos. Next slide, please. Here's a slide of diagnoses of HIV infection among adults and adolescents by age at diagnosis using 2015 data from the CDC. The number of cases that we're looking at in total is 39,393. And we see that the highest percentage is among 25 to 34-year-olds, followed by the 13 to 24-year-olds. So individuals between the ages of 13 and 34 represent almost half, 55%, of those cases in 2015. Note, the data includes persons with a diagnosis of HIV infection regardless of the stage of disease at diagnosis. The data that was pulled for this representation, for this bar chart, was for the year 2015, was preliminary and based on a 6-month reporting delay. Next slide, please. This is also from 2015, and this bar chart shows us new HIV diagnoses in the U.S. for the most affected subpopulations in 2015 again. So African Americans represented 12% of the U.S. population, but were overrepresented in the diagnoses. They accounted for 45% of the HIV diagnoses. Similarly, Hispanics, Latinos only represent about 18% of the U.S. population, but they accounted for 24% of these HIV diagnoses. And here we see the breakdown by race, ethnicity, gender, and sexual transmission. Next slide. For the purposes of this presentation, we're including data from New York. This is also from 2015. So in the work that we all do in our particular communities and our particular cities or rural locations, it's always good to be familiar with the publicly available data through your local health department, your state health department, to start to give yourselves a picture of what prevalence and incidence rates are occurring in your area. It's also important to understand that some state and city departments of health do not use the same terminology as the CDC. In other words, incidence versus a new diagnosis. Next slide, please. Now we're going to go into a bit of a discussion around HIV prevention and social determinants of health. So how do we address social determinants of health? Next slide, please. Social determinants of health are conditions in the environments in which people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. Next slide, please. Here are some conditions that affect social determinants of health. So for instance, economic stability, defined by poverty, employment, food security, education, for instance, whether one has attained a high school degree or not, whether one has attained higher education, language and literacy levels, neighborhood and the built environment, so whether one has access to healthy foods, quality of housing, and environmental conditions such as air quality or sanitation in one's neighborhood. Health and healthcare is another social determinant of health. Do you have access to healthcare? Do you have access to primary care? What's your literacy level in terms of health literacy? And then there's other social and community contexts, thinking of persons that might have had a history of being incarcerated, individuals that have had experiences being in the foster care system. Next slide, please. We can also understand social determinants of health looking at Bronfenbrenner's ecological model. So we can look at how each layer affects the individual as well as larger, higher levels such as community levels and geographic regions. Understanding these different layers of the ecological model and how they relate to social determinants of health can also help us understand modifiable risk factors, as well as larger societal factors that affect a person's health, as well as their community's health. We can think of different policies or laws that might affect someone's health. Effective interventions with the best outcomes often incorporate multiple components across all different layers. Next slide, please. Here's another look at the social ecological model. And it gives us an understanding of the relationship between how population groups experience a particular place and the impact of place on health, and how it is fundamental to the social determinants of health, including both social and physical determinants. Next slide, please. Here is a formula that we can look at to understand that behavior is a function of a person and their environment. As public health professionals, when we think of employing a particular intervention or evaluating a particular intervention, we want to see how these three different factors interact: a person's behavior, the person themselves, their beliefs, their values, and their environment, so the social determinants of health that surround them. Next slide, please. Social determinants can be measured in a variety of ways. One, availability of resources to meet daily needs, such as safe housing and local food markets. Another is access to educational, economic, and job opportunities. Third, access to healthcare services. Fourth, quality of education and job training. Fifth, the availability of community-based resources in support of community living and opportunities for recreational and leisure time activities. So these are all things that can be quantified. Another is transportation options, public safety, social support, social norms and attitudes, exposure to crime, violence, or social disorder, socioeconomic conditions, residential segregation, language and literacy, access to mass media, culture, and there are others. How do we put this all together in terms of HIV prevention? We can ask ourselves, do our services address all of these factors? If not, how are these gaps addressed? Are they addressed through partnerships that we have? What are some of the issues that might take precedence? For instance, do I need to be paid attention to before I can consider HIV prevention, treatment, and adherence? Do I need to find a place to live? Do I need to have enough food? Social determinants of health can act as a series of interrelated layers that combine to create a context of vulnerability and HIV risk. We can recognize the interrelated components of HIV risk as crucial to determining the most effective HIV prevention response. Let's think about what has to happen before an individual might take an HIV test. There has to be a certain level of knowledge, so that has to be available, accessible, and acceptable to that person. A certain attitude about taking that test, so a certain level of acceptability, and a belief, a certain level of acceptability. There's also predisposing factors that we can think of, as well as enabling resources and individual and community needs. All these factors go into play when someone decides to go in and actually take a test. Next slide, please. Here are some of the barriers to HIV prevention: racism, sexism, misogyny, housing insecurity, unemployment, poverty, stigma, education, criminalization policies, and the environment. And often some of these interact with each other to create a further barrier to HIV prevention. These barriers affect access to the things that could help people stay healthy. Next slide, please. So it's important to understand what these barriers are to HIV prevention in terms of social determinants of health in your own communities. We're going to use New York City again as an example and look at ways that we can gather that information from publicly available data. There's community profiles. The New York City Department of Health and Mental Hygiene releases surveillance reports, and there are other sources and resources that are easily available on the web. When thinking about how to identify social determinants of health in your communities, you should think about what's already out there. So review existing data, and then ask yourselves, do you need to learn more? If that's the case, you can do some formative research. You can do needs assessments. You can interview key stakeholders. You can also consider doing street intercept surveys or focus groups. And community observations and community mapping are always an excellent way of gathering information. So now we're going to go into the question and answer period. If you have a question, please use the chat box. You can also use the bar on the left to raise your hand, and we'll unmute you and you can ask the question. So the question that came in is what are good resources or good places to go to get more data? Going back to what I was mentioning earlier, really good sources of data are local and state health departments. So going onto their websites, seeing what reports or data is publicly available. The CDC also has data that's available for states and particular metropolitan areas. And for further SEBA on looking on identifying social determinants of health in your area, we will be sharing our Hands United contact information for requesting SEBA on this topic. A new question that's come in is, how does incidence inform my testing? So it's important to understand that incidence, again, this is a measure of newly diagnosed or newly infected or newly developed cases of a particular disease over time. So a good way of thinking of incidence for testing is when we're thinking about particular pockets or areas where there may be an increase in diagnosed HIV or newly diagnosed HIV cases, that can be useful in our recruitment, our engagement, and in our outreach efforts. We're going to see if there's time for any more questions. Okay, so a new question that came in is, how does prevalence inform prevention with positives? So that's a really great question, because considering that we're now understanding the importance of U equals U, and the importance of treatment as prevention, understanding prevalence gives us an idea of a particular area or a particular group of individuals, whether it's by age or by different risk factors, that even if there is a high prevalence, with U equals U, effectively there's no risk of transmission. So it's important for folks that are living with HIV to be actively involved in treatment and adherence so that they have undetectable viral load. And we're going to see if there's any more questions. Okay, so we have one more question. I think after this we may have time for one more. But this is a really good question. So what about what can I do with my own data in terms of incidence and prevalence? And so that really depends on what's available to you in your particular location, because not everyone has the ability to access whether the data that they're collecting, whether this is a newly infected case, or if this is a new diagnosis. But it's always important to think about, if you have an understanding of what the city and state incidence and prevalence rates are, and if you can look at that in particular to your priority populations, you can also calculate on your agency level what your positivity rate is, what the prevalence that you have among your community members is, and do like a rough comparison. Okay, so we don't have any more questions coming in, so I want to thank you for participating in our webinar today. Again, we at Hands United are available for CEBA under these 3 different components: high impact testing, prevention with positive persons, and organizational development and management. And here's some information on how you can request CEBA. CEBA is available to you for free. If you're a CDC directly funded organization, you can put in your CRIS request using the URL provided. For those organizations that are not funded directly by the CDC, you can contact your health department to help you submit a request. And again, thank you so much for participating. Have a great afternoon. Bye-bye.